It's a pleasure to be here at ASIP. I've been coming for several years and always enjoy it. What's left to be said, I'm not exactly sure. We've learned a lot about everybody is doing various guidelines, and I think the problem is we all think we're experts. I don't claim any expertise. I participated in one guideline on cervical radicular pain, which I have a slide on in a few minutes. I've participated in some of the intrathecal guidelines, which I'll talk about briefly, but I don't know anything about guidelines. I don't study them. I probably don't follow them very well. I tend to go with my own experiences over guidelines because I keep up with the literature and I try to make my own informed decisions about those things. I think that's what most of us do. I will highlight that I'm going to be the editor-in-chief of Regional Anesthesia and Pain Medicine. We're really going to try, as we start that this fall, to make it a more pain-inclusive journal. I think it's been too heavily weighted towards regional and acute pain, and I encourage your submissions. I will reject many of them, but I still encourage them. So what are the pros and cons? Evidence-based medicine, we've heard a lot about that today. Enhanced practice conformity. I think to the extent that we can all get on board and do things the right way, if we can all agree on what the right way is, that's good. Standard of care can then evolve from that unanimity of approach. We can avoid complications. I'm going to talk a little bit about that. Too many complications still occurring because people are doing things that they shouldn't be doing. We have compliance with many of the procedural guidelines of 50% or less. Research. We can actually formulate the questions that will answer some of these deficiencies in our guidelines and our current research database. I think guidelines can stifle innovation to some extent, however, because they do make you practice by that algorithm, so people are a little bit less venturesome to go outside of it. It can institutionalize bias. Look at the occupational medicine guidelines. We see within the workers' compensation forums that we really limit the types of therapies that can occur and get treated. They can erroneously be applied to similar patient scenarios. So we can take guidelines that were designed to treat radiculitis and we can try to apply them to spinal stenosis. Well, those are not the same condition. And I think we really go wrong when we do those sorts of things. We talked about the limitation of access already. I think the problem with most guidelines is they don't really say anything. I had a lecture when I was a fourth-year medical student by one of Eugene Braunwald's disciples, and it was a big thing, medicine. There were 200 people there, and the title was A Cold Cup of Water. And really, if you look at what Rick Dio and a lot of people are trying to do when they look at these different guidelines, nothing works. Well, we got to do more than that. We got to give our patients more than a cold cup of water. So I think it's appropriate for us to read the literature ourselves, to try to operationalize what we think, and actually to look at the guidelines and take what's good in them and reject the bad. Guideline wars, unfortunately, are present. I think they're undermining our cohesiveness as a specialty, and I think I'd like to see more of the societies get together. Some of you know that there's a new thing called the Council of Pain Physician Societies. We've been trying to get all the various pain societies together to be more uniform in the way that we do things. We respond to governmental or insurance things more cogently, but we're really not getting very far with that so far, unfortunately. I think evidence-based medicine is a great concept. We want to apply medical certainties, the things that we know work on a consistent basis and result in preferred outcomes. That's what everybody's goal is in here. But unfortunately, we go back to our own experiences. Everybody wants to do what we think works, so you guys are all just like me. Much of our evidence is likely to come from our preconceived notions. Lax alluded to that already. I think it's very, very true. And I think the RCT has been canonized by everybody, and RCTs aren't necessarily the best way to evaluate evidence, particularly in interventional pain or other surgical specialties. This is just a recent paper that Lax and others wrote about the American Pain Society guidelines. They actually went through this piece by piece. They were actually affirming of some of the APS findings, but unfortunately for some of the procedures such as caudal epidurals and facet nerve blocks and others, they found different results because there were articles that were missed or there was an inconsistent application of exclusion or inclusion criteria. I think we're all guilty of this, whoever's writing the guideline. We miss important papers. Even when I write a paper, sometimes I'll do a very exhausting search and then I'll find something in some obscure thing that didn't come up. And I'm like, God, where was that? And it's the nature of the beast when we're looking at this exhaustive literature that exists today. Opioid therapy. We all do a little bit of this. I try to limit it to the extent I can, but we end up doing it because we just have to sometimes. But where's the evidence? Beyond 12 weeks, we have very little evidence. If you look at what the state medical boards do, this is the model policy for the state medical boards in all the various societies. I think almost every state has compliance issues with this. But if you look at that, it's a good plan. Evaluate the patient, take a history and physical, figure out what's wrong with them. Are they functional? Are they not? And then give them informed consent. Do we tell our patients about hypogonadism? Do we tell them about the risks of testosterone therapy? Do we tell them about the risks of other possible complications, immune function, et cetera? Do we do periodic review of our patients to make sure that they're still benefiting? Do we always document the 4 A's? You know, analgesia and lack of aberrant use and lack of improvement in functionality, et cetera. If you look at these guidelines that APS and AAPM did together, very, very reasonable thing to get together, a couple of different pain societies looking for evidence for chronic opioid therapy for non-cancer pain. So they convened an expert panel. And they said, although the evidence is limited, the expert panel concluded that opioid therapy can be effective, but they did detail the potential serious harms. And they go on to say that all these things are important: risk stratification, getting an agreement to prescribe the opioids by, monitoring for side effects and other problems, indications for high-dose opioid therapy and when to say that that's good or bad, whether you can drive or not drive, how you can have a medical home sort of set up. But if you look at these guidelines, they were written by a panel. You can actually go online to this particular publication and you can pull up a PowerPoint slide that they will provide for you of their conflicts of interest for this. This picture is around Mardi Gras time, and we had a little party in my division, and the guy on the right of me there is Steve Pasick. Steve is a psychologist. Most of you may know of Steve. He's written extensively about opioids and addiction and psychological aspects of that. But he's a little bit different than the classic psychologists that I normally work with. When I've been working with a psychologist in the past, I wanted to refer to somebody to do cognitive behavioral therapy, help the patient develop better coping skills, et cetera. But Steve is really a pharmacologist. He really believes in opioid therapy. And I think if you look at the members of that panel, most of them, except Dr. Chow, had some sort of a conflict with the opioid industry. And according to LACS, Dr. Chow has his own conflicts with research support for his Oregon health science area and other things. So I think everybody ends up being biased the more you look at this. We all have our demons in the closet. The ACIP guidelines, I think, are very comprehensive and thorough, and they're cited often, and they're actually very responsible for the high impact factor that the journal currently has. But the ACIP guidelines are biased too, because it's pretty much done by interventionalists. And I think it would behoove you guys that are involved in writing the guidelines to get more people that are non-interventionalists involved, because I think it would actually improve the acceptance in the broader community. This is a guideline that Andrea Trescott wrote for ACIP, which I actually think is a really nice one. It's about opioids. And it has some of the same features that we look for in that model policy by the state medical boards. Doing a good history and diagnosis, developing a therapeutic plan, instituting other modalities to help with the problem, assessing the risk to benefit ratio, establishing treatment goals, getting an informed consent agreement, an opioid agreement, Starting the doses off, like an antihypertensive. It's not a guarantee of continued dosing. This is a trial therapy I'm going to institute to see if it will help your pain. If they don't have analgesia or if they have side effects, then you set up initially a plan about how you're going to discontinue the drug, and you discuss it with the patient. Step 8, stable. If they're stable, then you keep them on that dose, you follow up monthly, and you continue to assess those 4 A's: analgesia, activity, aberrancy, and adverse effects, and you manage those appropriately. Step 9, adherence monitoring. You do drug testing randomly. You do pill counts. This is now required in my state. Everybody that has to certify that they're a pain clinic has to register. There's a fee to do that, and every time the patient comes in, you have to do a pill count. Once again, if they fail, you discontinue the therapy. But in spite of all this stuff, we still have these pill mills. You heard about all this yesterday, and I can tell you this is alive and well in my state. And you can see from the study yesterday, or the lecture yesterday, that the opioid analgesic problem is just burgeoning. It's the biggest public health problem we have in the US right now, is the use of prescription drugs by illicit means. ASRA, of which I am an officer right now, has many good guidelines, but I would say that these guidelines, which I commonly use for my practice, I have to apply guidelines that were developed for a regional anesthesia acute pain practice to what I'm doing in the interventional pain clinic, which is not always that useful. But I stop the warfarin 4 to 5 days ahead of time. I stop the clopidogrel 7 days ahead of time if I'm going to do a procedure. If they're at high risk, sometimes I bridge. When I was at Mayo, one patient that we bridged had some facet medial branch blocks done and developed a deep muscle hematoma. We had another patient that was taken off warfarin for 4 days and stroked. Sometimes you're damned if you do, damned if you don't. Trying to use guidelines to guide your practice about what you're going to do with these sorts of things. But I would like to see somebody come up with guidelines that were actually more appropriate for these issues for what we do in the pain clinics. New drugs, new problems. There are umpteen new drugs that are going to be looking at clotting factors and antiplatelet effects, et cetera. And this is just one of the many things you can find on the web right now. Somebody's always looking to, take us away, I guess. So the problems with the ASRA guidelines, I talked about the acute pain perioperative audience and nothing for pain practice. This is a guideline that I actually got presented to me several years ago, probably in 2006. It came to my attention as part of a task force, and the AAN, which is the American Academy of Neurology, sent this to us for our look-see. When you write guidelines or you come out with practice advisories, it's very common to send them to other societies and to see what they think. If you look at this, they looked at the current literature. They didn't look at a number of studies. They excluded some of the better studies, in my opinion, and their literature search was about 2 years old at the time that they came out with this. But they said that epidural steroid injections for lumbosacral radicular pain have no impact beyond a short period of time, and they didn't recommend them. They were right about one thing. They're concerned that there's an underreporting of serious complications with epidurals, and that came out later. And for cervical epidural steroids, they said there was insufficient evidence to even talk about that. Well, what options do we have for treating cervical radicular pain? We can do a decompression infusion. What's the evidence for that? It's fairly nominal, actually. Physical therapy or traction, same. Pharmacologic therapies, there's pretty decent evidence that the alpha-2 delta drugs like gabapentin or pregabalin have some efficacy. Decent evidence that the nonsteroidals do something, but TENS units, not really very effective. Cervical injection therapy, we've already talked about a little bit. So we're end up, again, cold cup of water. What are we going to do for these people? We have nothing that we can actually offer them. I always show this slide whenever I talk about anything to do with cervical radic, because the bottom line is if we do nothing, the patients tend to get better with the passage of about 1 year. Lots of different approaches. Nobody's really come out with a real concrete prescription about how we should do these procedures. You can see that when we do an interlaminar approach in the midline to treat a cervical radiculitis, we endanger the cord. It's right in the line of the needle, basically. And if we haven't done a pre-procedural MRI to document what kind of a depth we have, how thick the ligamentum flavum is there, et cetera, then we haven't really done the planning we need to do that procedure properly. How about transforaminal? We all know many of the problems that can occur with that. So here's just a picture showing both approaches. I actually wrote a guideline a couple of years ago for pain practice and WIP with Dr. Van Zundert. And Jan and I tried to look at the literature and come up with what we thought was best practice. If you look at this on the left side there, we have interlaminar corticosteroid injection, and Lax has already presented the evidence for that procedure. Many of the societies now have come out against the transforaminal approach. But we have this in our algorithm, confirmation of the presumed causative level with a selective diagnostic block. How many people do those in the audience? Very few. I still do them, and I'm the guy that's vilified the entire procedure. I do tons of them. Our surgeons like them. I actually think they're helpful sometimes. And when I put the needle there, I almost feel compelled to put a little bit of steroids sometimes, because otherwise it just seems like a stupid procedure if I'm just doing it for diagnostic reasons. Down at the bottom, spinal cord stimulation, that's pretty much my next step. All the intervening things between the two right-handed circles are things with pulsed radiofrequency and heat radiofrequency, which I often don't do for the cervical radiculitis that's chronic. So I'm guilty of my own biases in my own guideline. We used evidence scoring that many of you have seen before. This is one of the 80-some types of evidence scoring that Lax affirmed. And when we looked at this, interlaminar epidural steroids came out with a 2B+, transforaminal 2B-. The Anberg study was the main one there, where they did a randomized controlled style with preemptive diagnostic blocks to prove the patient had radiculitis, and there was no difference between the placebo group and the treatment group. RF of the DRG, 2B+, pulsed RF, 1B+, but again, Jan Van Zundert was my co-author on this, and he was the one that had done most of these studies with pulsed radiofrequency. So again, another source of bias. Injectate guidelines. We don't really have anybody that's publishing guidelines that absolutely recommend the disuse of particulate steroids, particularly in the cervical area. And there's an FDA panel that I'm serving as part of right now that's actually looking at this. We're going to try to come out with some sort of a recommendation from the FDA about how to do these or not. But even on that panel, Nick Bogduck and Charlie April are part of it, and they're a little bit reticent to take particulate steroids out of the equation. So is Paul Dreyfus, a little reticent to take those out of the equation. But yet I've seen personally and participated in review of legal cases this year of injuries as low as L5 from particulate steroid, L5. So those of you that think you can do a particulate steroid transforaminal between L3 and L5, think again and think strongly. We've got a poster at this meeting that shows that DSA doesn't always prevent these things. And this was the case in one of the legal reviews I did. So these things are still happening. ISIS Standards Committee, they have come out with some very strong statements on their website. They talk about systematic reviews propagated by organizations and individuals who have neither conducted any of the original research or have meaningfully contributed to the literature, and they're trying to deny reasonable, biologically plausible care. It's a deliberate misrepresentation. You can tell that Dr. Bogduck had something to do with this very eloquent statement. The last paragraph, we need to reappraise the methodology upon which evidence is based for interventions such as injections, radiofrequency neurotomy, surgery, or intradiscal therapies, and not unlike in other surgical domains, cannot be assessed in a manner analogous to non-invasive drug trials. Very, very true. I mean, again, to make the statement I made before, we're no different than the surgeons. A lot of this stuff just doesn't work for evaluating the outcomes of our procedures. We want to avoid things like this. I really believe we need to come out more strongly with some of the complication avoidance sorts of things. This is just from a study I did a few years ago. But this is a real nice neuroradiology study that one of my friends at Mayo, when I was there, Tim Moss, did, just to show that the safe zone is the highest area of vessel prevalence when we're doing these in the lumbar region. We all know this, but again, our guidelines and our procedural therapies haven't really changed that much if we look at our global adherence to that. Jim Rathmel looked at the ASA closed claims. I don't know if you guys know what the ASA closed claims are, but it's a look back at legal suits that have been brought when injuries have occurred. If you see here for cervical procedures, these are huge, and they've increased dramatically over the last couple of decades in terms of the number of injuries associated with cervical injections. If you look at what's going on, though, the vast majority of these, about almost half, are actually related to trauma caused by the needle through an interlaminar approach. So I've made the case a few times that the interlaminar approach may be just as dangerous or more so than the transfemoral approach. You have to be very, very careful with your needle. At Vanderbilt, we're developing algorithms. We're developing our own algorithms because I like what we put down better. We try to look as a group at what we're doing, and we're trying to standardize our practice to some extent. Intrathecal therapy. Lax alluded to this. The last review that Vic Patel led didn't really show great efficacy for intrathecal therapy for chronic benign pain. But I think a lot of that is we're just not picking the right patients. How many people in the room think an intrathecal pump will work for a patient getting 360 milligrams of OxyContin with a pain score of 9? Raise your hands. Exactly. But yet those are the people we tend to put intrathecal pumps in, not the elderly woman who takes a couple of tramadol and gets dizzy and constipated. And she's probably the one that would do best, maybe with a microdosing sort of paradigm. Who knows? But we're picking the wrong patients. How many people, every time the patient comes back and their pain score is greater than 5, do they increase the dose by 20%? Most of us. And then people like me in academia get these patients that are getting 60 milligrams per milliliter of morphine when we know that it comes out of solution at much, much lower levels than that. And they're getting 50, 60 milligrams a day of these drugs, and yet they're still reporting high pain scores. We just don't do a very good job of managing these problems. These are some new publications that are out on the online version. They'll be coming out soon. They're the newest consensus guidelines. This is one for intrathecal trial. Essentially, it just says if you've got nociceptive pain, consider doing a single shot intrathecal trial. If you've got neuropathic pain, consider a catheter trial. Make sure that you're picking the right patients, that sort of stuff. For the diagnosis and treatment of granuloma, if the patient's developing new sensory symptoms, you need to look at that: burning, tingling, hyperalgesia. You should be monitoring these patients very, very well if they've got a granuloma-inducing concentration that you're infusing. Prevention, bolus dosing. I think there may be something to that. If we're intermittently given boluses, like on the patient therapy manager function, you may be able to just blow off the end of that catheter periodically, and that may prevent the development of a granuloma. Or you can switch to a different opioid or to zigonotide or another adjuvant, and that may be helpful too. So basically, these guidelines I think are good. I know my participation wasn't that much, but we really exhaustively did this over a period of several months with a big group of people, and we tried to do a good job of coming up with reasonable guidelines for our people like you. Take the patient history. I saw a patient once that under direct vision had an academic neurosurgeon put the intrathecal catheter directly into the spinal cord parenchyma. Published that a few years ago. This stuff happens. How did he present? Increasing new pain, hyperalgesia, sensitivity, etc. And every time the dose was increased, it got worse. Well, so we investigated. We just did an MRI, and lo and behold, there it was. So you have to monitor this stuff very, very closely. So that's a lot of stuff. I don't know if I summarized or added more mud to the picture, but my summary is I think guidelines are good. They have a place. I commend ASIP and other organizations for trying to do a good job with guidelines. But to borrow from Romans 3:23 in the Christian Bible, we've all sinned and fallen short. We all have to try to do a better job of what we're doing with our guidelines, trying to be more inclusive of disparate opinions and come up with more unified approaches that everybody can agree in. I like algorithms better. I think they're a little bit more succinct. And sometimes the guidelines, they just make statements and don't really tell me what to do. And I think sometimes people really need that cookbook step-by-step approach. And I think Lax and others are right in that comparative effectiveness research for the future may be one of the things that really saves us, where we can directly compare different techniques. And final guideline, take care of the people you love, because ultimately that's all that matters, my wife and my daughters. Thank you very much. However, because they do make you practice by that algorithm, so people are a little bit less venturesome to go outside of it. It can institutionalize bias. Look at the occupational medicine guidelines. We see within the workers' compensation forums that we really limit the types of therapies that can occur and get treated. They can erroneously be applied to similar patient scenarios. So we can take guidelines that were designed to treat radiculitis and we can try to apply them to spinal stenosis. Well, those are not the same condition. And I think we really go wrong when we do those sorts of things. We talked about the limitation of access already. I think the problem with most guidelines is they don't really say anything. I had a lecture when I was a fourth-year medical student by one of Eugene Braunwald's disciples, and it was a big thing. I still encourage them. So what are the pros and cons? Evidence-based medicine, we've heard a lot about that today. Enhanced practice conformity. I think to the extent that we can all get on board and do things the right way, if we can all agree on what the right way is, that's good. Standard of care can then evolve from that unanimity of approach. We can avoid complications. I'm going to talk a little bit about that. Too many complications still occurring because people are doing things that they shouldn't be doing. We have compliance with many of the procedural guidelines of 50% or less. Research. We can actually formulate the questions that will answer some of these deficiencies in our guidelines and our current research database. I think guidelines can stifle innovation to some extent. Medicine, there were 200 people there, and the title was A Cold Cup of Water. And really, if you look at what Rick Dio and a lot of people are trying to do when they look at these different guidelines, nothing works. Well, we got to do more than that. We got to give our patients more than a cold cup of water. So I think it's appropriate for us to read the literature ourselves, to try to operationalize what we think, and actually to look at the guidelines and take what's good in them and reject the bad. Guideline wars, unfortunately, are present. I think they're undermining our cohesiveness as a specialty, and I think I'd like to see more of the societies get together. Some of you know that there's a new thing called the Council of Pain. It's a pleasure to be here at ASIP. I've been coming for several years and always enjoy it. What's left to be said, I'm not exactly sure. We've learned a lot about everybody is doing various guidelines, and I think the problem is we all think we're experts. I don't claim any expertise. I've participated in one guideline on cervical radicular pain, which I have a slide on in a few minutes. I've participated in some of the intrathecal guidelines, which I'll talk about briefly, but I don't know anything about guidelines. I don't study them. I probably don't follow them very well. I tend to go with my own experiences over guidelines because I keep up with the literature and I try to make my own informed decisions about those things. I think that's what most of us do. I will highlight that I'm going to be the editor-in-chief of Regional Anesthesia and Pain Medicine. We're really going to try, as we start that this fall, to make it a more pain-inclusive journal. I think it's been too heavily weighted towards regional and acute pain, and I encourage your submissions. I will reject many of them.